Good morning. I'd like to welcome everybody back to another episode of Coffee, Kids, and Sports Medicine. For those of you joining us online, please don't forget to scan your QR code here so you can claim your CME credits. And as always, we encourage participation from our audience with questions at the end of the lecture. There's 3 ways to submit for these questions. You can text us at the number here. You can email us at medicalprofessionals@tsrh.org. Or if you're logged into YouTube, you can utilize the YouTube live chat function. We'll get those questions in. We'll get them answered at the end of the lecture. Our course directors nor our speaker today have anything to disclose. Today I have the honor of introducing Dr. Jason Petrasic. Dr. Petrasic is the newer member of our family here at TSRH. He is a PM&R physician and an associate professor at UT Southwestern Medical Center. Dr. Petrasic practices out of both our Frisco and our Dallas locations. He has a special interest in non-operative management of scoliosis and other spine conditions. And today he's going to be speaking to us about the Adolescent Thoracolumbar evaluation. So I'll go ahead and call him up and let him talk to us today. Thank you.
Thank you. Hi there. Like Jared said, my name is Jason Petrasic, and I want to start, this is called Coffee, Kids, and Orthopedics, and I usually see a lack of coffee. So in honor of that this morning, we'll start it off right. Today I'm doing like Jared said, a talk on the Adolescent Thoracolumbar evaluation. So when thinking of a title of this talk, it seemed to me most relevant to go with a straightforward title, but just a quick side story. Posted, wanted to get the word out, so we actually have some people watching and learning something today. And posted the flyer that you've seen on Instagram and a couple other social media channels. And I got a comment from my chair, Dr. Bell at UT Southwestern, that, hey, why didn't you think of a little bit more interesting title? I said, well, I probably could have. I wanted to be straightforward. That way people know exactly what they're getting. But I said I should have let my 2-year-old daughter name the lecture. So, fast forward, I take it to her, just show her the same picture of the title, and she kind of looks at me and says, poo-poo. I said, well, I don't know that I would have called it that, but, hopefully it's not foreshadowing things to come. So with that in mind, we'll move forward. Today I have nothing to disclose. And the objectives today, pretty straightforward, really. I want this to be pretty clear, concise. I want you to walk away knowing, hey, I feel much more comfortable doing a basic thoracolumbar exam. And after the activity, I want you to be able to describe some special tests for the lumbar evaluation, describe 3 abnormal findings in a lumbosacral exam in a child, and just be able to explain a basic differential diagnosis for back pain in adolescents. And with that in mind, I think through the pandemic, we've really all noticed that, or maybe it's just happenstance that we've seemed to notice that back pain seems to be becoming more prevalent. And is that because a lot of kids have been a little bit more stationary, they're not moving around as much, sports kind of halted for a while, and I think that's no coincidence, but I think time will tell. There's likely some ongoing prevalence of back pain during the pandemic studies going on, so I think we'll see, but I think it bears noting that it's definitely not uncommon in kids, just like it's not uncommon in adults. And just basically, the goal today is really, and the focus is the exam, but I'd also be remiss if we didn't go over some basic anatomy, history, imaging findings, some things to get us started. The other thing I don't want to do necessarily is repeat a quote-unquote back pain lecture, because in looking at some of the prior and listening to some of the prior Coffee, Kids, and Orthopedics lectures, Dr. Sanders did a great lecture last year on back pain in youth. And so I wanted to really kind of complement that, but take it a little bit step further and dive into the exam portion. So looking at basic lumbar spine anatomy and the bones in particular, and soft tissues for that matter within the spine, I think it's very the easiest way for me to break it down and think about back, or something as complicated as something that can be as complicated as the spine, is to look at it in columns. And that's what I think most of the spine docs try to do. And that there's really 3 columns. There's an anterior column, which you see outlined in blue here. And that primarily includes the anterior 2/3 of the vertebral bodies, as well as the anterior 2/3 of the intervertebral discs. And so when you're thinking about low back pain, things like pain worsening with sitting, pain worsening with bending forward, that's going to put a lot more pressure on your anterior column, hence a more likely pain generator there in your anterior column. Then you've got your middle and neuroaxial column. That's primarily the intraspinal canal, includes the pedicles, the posterior 2/3 of the vertebral bodies and discs. But think, radicular pain, tethered cord, different things that can go on within the spinal canal, syrinx, spinal cord, spinal nerve roots, and predominantly, remember, and we'll go over this a little bit later, in the lumbar spine, the inferior portion of the cord ends at about L1, L2. And so really from there down, most of the lumbar spine is nothing but lumbar nerve roots. So just something to always keep in mind. Oh, whoops. And lastly, the posterior elements, posterior column, posterior element pain. Whoops, I need to keep my finger off the button there. You've got primarily your bony posterior elements, i.e. the pars interarticularis, the facets, also the ligamentum flavum and the supraspinous ligament. So kids coming in with a lot of extension-related pain, hyperextension-related pain, hyperextension-related injuries that are going to hurt more, typically worse and more with hyperextension. You'll get more pain related to that posterior column. And when looking at the nerves, the neural anatomy, important to remember, unlike the cervical spine and the lumbar spine, the nerve roots exit below the vertebral body that they're associated with. So, for instance, at the L3, typically you'll get L4 exiting at that level below. At L4-5, you'll get the L4 nerve exiting at that level. Excuse me. The other thing to remember is so that's far lateral in the spinal column. More centrally or posterocentrally, you'll get some of the descending nerve roots. So keeping in mind, when you get herniated discs, if you get a far lateral herniated disc, it's more likely going to irritate or impinge on that exiting nerve root. Whereas if it's a more centrally herniated disc, you're more likely to get irritation or impingement or inflammation in that descending, in this case, the L4 nerve root that's exiting at the level below. And then looking over at the other picture here, also just wanted to illustrate the medial branches. So when you think facet or posterior element pain, you get the nerve root exiting out of the neuroforaminal canal. You get the dorsal root ganglion here, and then from that you split off the dorsal primary ramus, and then here posteriorly it comes back around to innervate the nearby facets and the posterior elements. So think, we see this a little bit more in adults, but even in kids sometimes, if you see a nerve block or a medial branch block, that's something that's done primarily to denervate the facets and to help denervate the posterior elements. So I put this up here, really wanted to just kind of make the point, in looking at both these images. One, obviously there on the left, that's going to be a more degenerative spine, somebody much older, and here what is basically a normal MRI. But really the point is, what's causing low back pain here? Over here there's a lot of findings, a lot of potential pain generators, and you'll hear me say that a lot. What's the primary pain generator here? And what is potentially a secondary pain generator, and that can be difficult to discern. But in just looking at an MRI, you're rarely going to be able to look at it without examining the patient, taking a good history, and putting it together to discern, is it the disc? Oh, you've got a herniated disc, or you've got potentially a vertebral fracture or spinal stenosis. And similarly, likewise, you've got a normal MRI and somebody with, let's say, low back pain. What's causing pain here? It's essentially a normal MRI, so it's not going to tell the whole story, but obviously helpful augmented information. So in brief, in starting with a really good history, because that's to me what's really important. What is the chief complaint? Are they coming in complaining of neurological symptoms, either at the waist or below the waist in the lower extremities, or is it pain? Are they having low back pain? Does the pain radiate? Does it radiate into the lower extremities? If so, specifically, outline the distribution of where your pain is radiating to. What is the age of the patient? Back pain in a 5-year-old is very different from back pain in a 15-year-old. Again, the focus here is on the adolescent exam, but even so, back pain in a 10-year-old may be much different from back pain in a 17 or 18-year-old. History of prior lumbar injury. Have they had lumbar injuries before? Have they had low back pain in the past, or is this the first episode? Have they had any issues there? Have they had a diagnosed injury before? The chronicity and progression, obviously important. The location of pain radiation, back versus leg pain, or is there back and leg pain? If so, which one's worse? Is the leg pain worse than the back pain, or vice versa? Is the back pain worse than the leg pain? Very helpful. Sport, do they play one sport? Do they play multiple sports? Do they play all year round? Do they take any breaks? Are they sport specialists, or are they in a sense cross training? And what's their level of competition? In a gymnast, are they a level 1 gymnast? Are they a level 4? Are they a level 9? There's a lot different expectations and a lot different demands on those bodies depending on often the level of competition that they're playing. Looking at the mechanism of injury, was there any trauma, or was there an injury involved at the onset, or was it relatively atraumatic and an insidious onset? It just kind of started and has slowly progressed, or no? I remember that one time I fell off the monkey bars and landed on my bottom or landed on my back. That's going to direct maybe a little bit different exam and workup. Any exacerbating positions or activities, very, very helpful. Like I said, is there more pain with prolonged sitting, prolonged standing? And the kids are not often going to tell you that. It's something I've kind of got to pull out of them. Does it hurt worse, or in this position, or what makes it specifically worse? Or what position or activity do you avoid because it aggravates your pain? Repetitive loading, also important to remember, because that could obviously hint at maybe a posterior element, possibly a spondylolysis or a pars issue. Are there neurologic symptoms associated with it, as I hinted at in my previous slide? Obviously a very important thing to ask about and examine for. Prior treatments, have you had any previous treatments? One of the most, I think, kind of annoying things to me is when I get through a full exam and I've asked about, hey, have you had these, any treatments before, specific treatments? I'll even go over them, and then we start talking about what my proposed treatments will be, and they tell me, oh, well, I tried that, oh, I did that, and I've been to a physical therapist, I've been doing some home exercise. Oh, okay, you didn't mention that, so helpful to know those ahead of time and if they helped or not. And then a social history. History of IV drug use there, IVDU is what I mean by that. Obviously, that's going to be, hopefully, if at all, it's going to be in your older adolescent, if at all, but still important to ask some of those things. Are they a smoker in a 16, 17, 18-year-old? Do they e-smoke, or do they vape? And then obviously, if there's a certain clinical concern, then the IV drug use is important to know. Red flags that I always ask about, and I preface it with that. Hey, I'm going to ask you some questions I ask everybody just to be certain and to inquire. Are you having any bowel or bladder incontinence or irregularities or changes? Specifically, what I'm looking for there are, and again, this can be tough in a 10 or 11 or 12-year-old, but I say, hey, or if it's older, do you know what urinary incontinence is? Almost always it's no. So then, when you go pee, do you have accidents, or do you accidentally pee from time to time when you don't mean to? And usually they get that, and they say no, and hopefully no. Or if when you're going to the bathroom or you're going number one, do you feel like you fully empty your bladder? Do you get it all out, or do you always feel like you need to keep peeing? Really getting at urinary retention. So are they having any incontinence or retention are the two main things I'm looking for there, hinting at an intraspinal problem. Are they experiencing any fever, chills, malaise, any unexplained weight loss or loss of appetite, history of cancer, either in them? I'll also ask about a family history of cancers. Do they have any consistent nighttime pain disruption? In particular, is pain waking them up at night? Are they waking up in pain? And how consistent is that? Did it just happen once or twice, or is it happening almost every night? And then, although this is an adolescence talk, my antenna raises up a little bit more if they had pain, or they are a 5-year-old or younger with pain. Differential diagnosis, I put this slide up primarily just to kind of hint that, yes, there's mechanical causes of back pain, there's radicular causes of back pain, but there's also, don't forget about visceral problems. In particular, I think this is, I took this from Up to Date. I think it's a good kind of overall review of the causes of back pain. And so some of this obviously isn't applicable to kids or adolescents, but things like pancreatitis, stomach ulcers can still happen in your adolescence. Things like kidney, urinary tract infections, kidney problems causing pain can also cause pain in the back or the flank. So important to keep those in mind. So when thinking and approaching back pain and developing a differential, looking at the nuts and bolts of things, what are we dealing with? Does from the history and even before the exam, does this sound like we're dealing with axial mechanical pain, structural type pain? Is it myofascial, i.e. myo being muscle, fascia being the kind of thick soft tissue envelope of the muscle? Is it soft tissue related? Is there a radicular source of the pain or a neuropathic source? Is it traumatic back pain or atraumatic back pain? And is there any referred pain pattern associated with it? And looking at pain referral patterns, important to note when somebody's, just like in the hip or the knee, when somebody's complaining of back pain, where I like to specify and have them kind of outline where they feel pain. Often we'll even use a pain drawing, a picture of a body so that the kid or the patient can draw where they feel pain, because you'll see all kinds of pain patterns. And so this slide nicely illustrates some studies that have looked at referred pain patterns in large numbers of patients. When you look at posterior pain in the posterior elements, the lamina, the pars, the pedicles, or excuse me, not the pedicles, but the lamina, the pars, the facets. Often it's right here centered in the side of the low back, but you'll also see a little bit of referral down the side of the proximal thigh or hip. SI joint pain, also a lot of overlapping pain where you also might see hip pain, which is seen over here, both in often in the anterior groin or the posterior buttock. SI joint pain is kind of in this posterior buttock, but it also, they may express pain down the thigh, the posterolateral thigh, even down to the knee in some cases. And then discogenic back pain, this nicely illustrates kind of the primary pain area of discogenic pain, but you'll see often, we think of radicular pain as only being associated with pain radiating past the knee, but in looking at even some patients with discogenic pain, they reported some pain at the knee or just below. So again, just a general guide to know where the pain is going and where it's radiating, but try not to box it in so much. Keep the differential still broad. So finally, getting to the physical exam. I think of it best, especially for somebody maybe just starting out in training or that doesn't have a well-polished musculoskeletal exam. Keep it simple. Take it back to when you learned it in grad school or postgraduate school. What is a musculoskeletal exam? It's inspection, it's palpation, it's range of motion. I mean, that's the basic principles of a musculoskeletal exam. Beyond that, yes, we want to do neurologic testing to rule other things out and evaluate for other intraspinal problems, and we want to occasionally do some special or provocative testing to help narrow down either rule in or rule out things. But you don't always have to do every special and provocative test that you've got in your book. You know, try to orient your special and provocative testing to those problems that the problems that are highest on your differential. So in starting with inspection, it's just that they've really got to be, to do a good inspection, you've got to have them exposed. So I always have them come in shorts. For the guys, I can simply tell them to remove their shirts. Some can be a little bit more shy than others. So in them, I ask the medical assistants or nurses, hey, if you kind of sense that there's a little bit of shyness there, you may ask them, hey, do you want a gown to change into? Because I've actually had a couple tell me they'd rather not take their shirt off, so we go ahead and have them change. And girls, the same thing. We have gowns that we have them change into, and we have some shorts available for them as well. So if they're coming in and they let your staff know that they've got a chief complaint, whether you're in primary care or in physical therapy or a trainer, then and you have a staff, then go ahead and have them make sure they change into the appropriate clothing. So I want to look at them primarily. I always start in standing. It's kind of easiest to see everything on the back. I've picked up a lot of things over the years. You can look at the spine curvature. You can look at the iliac crest height. Does it look symmetrical? And I want to preface with this too. I'm going to go over all of this in a demonstration video later in a little bit more detail, but I just want to touch on it and comment here. You can look at shoulder symmetry, pelvic obliquity. You can look at the entire kinetic chain from the foot all the way up to the knee, the hip, and the low back to identify any potential foot problems. Do they have severe overpronation and flat feet? Are they severely valgus at the knee, hinting that could get propagated up to the spine and cause some back pain issues? Have them do a single leg stance and see if there's any balance issues. And then I also want to observe their gait, both in toe walking, heel walking, and tandem. Gives you good information, both looking at balance, looking at plantar flexion strength, and dorsiflexion strength. And then in supine, you can also do this in standing, but I'll commonly do it while supine. Is I can measure if they have a leg length discrepancy. I can screen really quick, just put my thumbs on the medial malleolus and try to make sure that their legs are even and they're lying down flat, and check for any obvious discrepancy. If I want to take it a step further, I can bring out my tape measure and measure the leg length, measure for either an acquired leg length discrepancy, or a functional leg length discrepancy or a true leg length discrepancy. And then also what we commonly do, especially in our patients that we're screening for scoliosis, I also will often include it in just looking at when I'm assessing range of motion, because it's essentially the Adams forward bend test. You're asking them to bend forwards and bend over and try to touch their toes. So at the same time, I'm looking to check their trunk flexion. I can look and assess their spine. I look for any prominence of the rib and the thoracic cage. Look for any fullness here in the lumbar area, and look for any asymmetries really. Looking at, moving on to the palpation portion, it's really important when palpating. Yes, you can try to palpate for where the pain is located, but also important to know what you're palpating, or just as important. So some of the landmarks that I'll use to help identify kind of where I'm at, that L4, L5 is right there. So if you palpate for the iliac crest and go directly over, right here, that's usually at about the L4-5 level. So you can know if you're to help you when you're palpating for the spinous processes, or approximately what level. Here at the PSIS, that's at approximately the level of S2. And then typically what I'll do, and it's important if you're doing this to try and make it a routine, I'll typically start in the paraspinals on both sides, palpate with light pressure down the paraspinals, palpate down the midline over the spinous processes and the spinous ligament, I'll palpate out over the soft tissues, the myofascial soft tissue here across the low back, palpate down over the PSIS and the SI joints just underneath it. Then I'll palpate out over the iliac crest. Then I'll come down, palpate over the piriformis, which typically runs from the sacrum over to the greater trochanter. Palpate over the greater trochanter to see if there's any trochanteric pain. And then come back, and lastly, I'll palpate over the ischial tuberosity to see if there's any kind of gluteal pain or pain at the origin of the hamstring tendons. Range of motion. So looking at range of motion, and I'm going to give you the values, the typical values of the range of motion, and then also how we'll describe it when documenting range of motion clinically. So typically with a trunk flexion, you get on average about 60 degrees of trunk flexion. Now keep in mind when bending forward and assessing it clinically, you're not only getting trunk flexion, you're getting hamstring flexibility in there as well. So important to remember that. It's just a kind of a general guide when you're evaluating clinically. These typically are done and evaluated with a goniometer and in a higher level fashion. So just something to note. In extension, you'll typically get about 20 degrees of extension. Side bending, you'll get approximately plus or minus 31 degrees, and rotation plus or minus 32 degrees, or 32 degrees plus or minus. In the hip, you can also do this in supine, because obviously once I have them down, I'm assessing hip strength and doing some other special testing. If I've got a concern that there's possibly an underlying hip problem, it's real easy to lift their leg up and take them through hip range of motion. So I'll commonly assess that as well when clinically warranted. Almost always, especially in my adolescents, I'll check popliteal angles, and what that's really getting at is how flexible are their hamstrings, especially in my adolescent guys. So doing that, you're examining them supine with the hips flexed to 90, and then with the hips flexed to 90, you just extend them at the knee and see what that angle is between in the pop fossa. And I'll demonstrate that later. Neurological examination. Want to check for manual muscle strength testing in all of the bilateral lower extremity myotomes, sensation both to light touch. Typically, I'll start there with light and soft touch. If there's a specific sensory complaint or they're complaining of some sensory symptoms, I may check for pinprick sensation. Yeah, you can do 2-point discrimination. You can do monofilament testing if you have those supplies clinically. And when warranted, you can also check for proprioceptive loss and vibratory sensory loss. I'll check deep tendon reflexes in the patella. Important to remember, patella is associated with L4. Medial hamstrings, don't commonly do that clinically. It's much tougher to pull out, but it is associated with L5 when you find it. And then Achilles can be associated or is associated with the S1 level. We'll do plantar stimulation, looking for a Babinski sign, or are there plantar responses downgoing. Look for ankle clonus, and then abdominal reflexes. And that's what this picture here is demonstrating. So just looking to swipe from the lateral aspect of the flank down towards the umbilicus, and you should typically get a wink of the umbilicus to that side. Typically, like with most neurologic signs, you're looking for asymmetries. I'm less concerned with, specifically in the abdominal reflex, with whether it's absent. You could argue with deep tendon reflexes, if they're absent, that could be a much bigger sign of a problem. With abdominal reflexes, I'm not looking as much for absence or presence. I'm looking for asymmetry. Is it present on one side and not on the other? And then looking at strength, just wanted to go over some of the main muscle groups that we'll test and what root levels that they're associated with. So going down from the hip flexors, typically, remember there's a lot of myotomal overlap. So it's not just one level innervating these muscle groups. The hip flexors is typically L1 to L3. I'm more commonly associated with, especially I'm thinking ahead. Hip flexors L1 to L3, hip abductors L5 and S1. knee extensors, so your quadricep muscles, L2 to L4, ankle plantar flexors, like when doing heel raises, L5 to S2, great toe extensor innervated by primarily L5, and then the ankle dorsiflexors, i.e. when heel walking and observing that, associated with L4 and L5, and then the peripheral nerves associated with those as well. So just in assessing strength, I wanted to insert a special test here. One way, if you're kind of concerned about the patient's effort that they're giving you, I find this is typically a little bit less of an issue with adolescents than it can be with adults, but something called the Hoover test was developed, and it's basically you're putting a hand under both legs. So they're in the supine position, you put a hand under both heels, and you ask them to lift the left leg. Ideally, if they lift that left leg or cannot lift that left leg and they're not putting any downward pressure with the contralateral heel, that's a sign that they may not be giving full effort, because if you're ever lying down and you try to lift one leg without pushing down with the other, it's pretty tough, and most people won't think about that. They'll instinctively push down with the other to lift the leg that they're being asked to. So again, just kind of a general way to assess for voluntary effort. Really no studies evaluating the reliability and validity of that, but again, it's one that I think can be helpful in the right clinical scenario. Looking at sensation, you want to keep in mind not only dermatomal distributions, but you also want to keep in mind peripheral nerve distributions, and where does it feel, and often you'll have both in mind if somebody's complaining of numbness or tingling or pain radiating in a certain area. So in general with the adolescents, I'll ask, hey, if you feel it, I'm going to check for your soft touch. Does it feel less on one side? Does it feel different, or can you not feel it at all? And that's to light touch or pinprick. Again, consider vibration and/or proprioception in the right clinical scenarios, and then you can take it a step further if you want to improve your clinical accuracy of the sensory testing and checking with a monofilament or 2-point discrimination. And then also, again, hinting back to the dermatomal and peripheral nerve patterns that are outlined both here and here. And then looking specifically at special and provocative testing. Excuse me. So put these pictures up primarily if we're looking at radiculopathies. Again, you're thinking of, in the athletic population anyways, typically sports where that involve a lot of trunk flexion, like cycling, like rowing there, puts a lot of force and pressure on that anterior column. So the main thing we'll do to check for a radicular source of the pain is a straight leg raise. Can also combo that with a contralateral straight leg raise or even a sitting slump test. And all those are kind of just variations of one or the other. And that straight leg raise is seen there in the picture here. All you're doing is passively lifting the leg, flexing at the hip with the patient supine. Typically, the most sensitive degree where you'll see the most pain is between that 30 and 70 degrees. You start getting above 70 degrees, you almost invariably get pain, it's hamstring tightness. They're complaining of pain that goes down the back of the thigh. And then you further specify and they tell you, oh no, it feels tight or feel pain in the back of the thigh. You're looking for reproduction of their radicular pain or their numbness, their radicular symptoms. So it should be pain that typically radiates down past the knee into that lower leg or the foot. You can also do it in sitting. That's done by doing the slump test where you have them sitting on the side of the exam table and you simply raise their leg passively. That's putting more neural tension on that sciatic nerve, trying to provoke that radicular pain. Those tests show good sensitivity, poor specificity when evaluated from a research standpoint. Contralateral straight leg raise, much more specific. So when you see that, it's almost, when you typically get that, that's almost invariably going to, in the right, if they're reporting radicular symptoms and pain that radiates and you get that positive contralateral straight leg raise, it's almost always confirmative. But you can see there the specificity ranges from 85 to 100%. And all that simply is when you're checking the asymptomatic leg and doing a straight leg raise, do they get radicular pain stimulated down that right side of the leg? or of the contralateral leg. Femoral nerve stretch testing, much less common to get a radiculopathy in your upper lumbar nerve roots, those femoral nerve roots. But in the right clinical scenario, if you're concerned for it, you put the patient in the prone position, and just as the picture shows here, you flex their knee, and typically you forcibly flex their knee. You can take it one step further and put them in a little bit of hip extension, just to, again, put some tension on that femoral nerve. Sensitivity is good there with 85 to 95%. It's probably the single best test to evaluate for a lumbar radiculopathy secondary to an upper lumbar disc herniation. Looking at mechanical back pain. So the main thing and the main test that we'll use, especially in kids, and unfortunately the validity is not well established, at least on the physician and APP side, we'll use it as a provocation for axial back pain, primarily looking for that pain in the posterior column, call it the Stork test. There's a small variation, especially in adults, that we'll use is called facet loading, looking for facet-mediated pain, but it's essentially the same test. What you're doing there is having the patient raise one of their feet off of the ground, that foot that they've got raised in the air, and often I'll steady them with both hands at the shoulders, but I'll have them extend at the hip, like he's doing there, and then extend back at the waist. Put them under lumbar extension, put that posterior column under an axial load, and seeing if it provokes their typical pain that they feel. Now, I do know, in talking with some of our physical therapists, they do a variation of this same test that they also call the Stork test, and that's looking more for SI joint dysfunction, SI joint irregular motion, except that I believe the variation that I've seen is that they, instead of extending at the hip, they'll put both thumbs at the PSIS on both sides and then have them flex at the hip, and they're looking for abnormal motion of the SI joints and those PSIS as their indicators. But this is typically how we'll use it in our clinics. Excuse me. I wanted to comment on the modified Schober test. It is a test, especially when you're thinking of, hey, they're complaining of some stiffness, because we do see things like ankylosing spondylitis and some of the seronegative spondyloarthropathies in our late adolescent or late teens, early 20s population, primarily. And it's a test done to assess lumbar flexion. There's a Schober test, a modified Schober test, and I believe the modified Schober test, which I think is taking it a little step too far. But essentially what they're doing is you're making a mark, you identify the lumbosacral junction, again, typically using that PSIS, those PSIS marks, the little dimples that are typically in some people on the low back. Making a horizontal mark, you measure 10 centimeters above, you measure 5 centimeters below, with them standing erect, and then you have them bend forward like they're going to touch their toes. And if they get, excuse me, that distance there when measured standing is 15 centimeters. When they bend forward, it should not exceed 21 to 22 centimeters. If it does, or excuse me, it should. That would indicate good flexion. If it does not, then that indicates some stiffness. And again, that's part of that decreased lumbar spine mobility is a part of the diagnostic criterion for ankylosing spondylitis. Again, lack of good high-quality studies assessing validity. There are some studies that have shown a good correlation with radiographically assessed range of motion, but none, at least that I could find, with any high-quality studies. And then I did want to comment on sacroiliac joint dysfunction and arthritis. Some of the special testing we'll use there. Wanted to make a note to include the Faber test. I will do this in almost anybody complaining of low back pain. It's very simple to do, and it's easy to do when they're in supine. As the name, there's a number of names for it, most commonly called the Faber test. Some will call it the Petrasic test. Some will call it the Patrick-Faber test. Either way, I like Faber because it, as mentioned or as noted right there, it's flexion, abduction, external rotation, so easy to remember. And it's important when doing this to distinguish between does it provoke anterior groin pain, i.e. hip pain, or posterior low back pain, indicating potentially SI joint pain. You stabilize the contralateral hip, have them externally rotate, the hip being examined. Usually put that foot right over the contralateral knee, and then I'll apply force in opposite directions, trying to reproduce their symptoms. Decent sensitivity, not great specificity, but again, it's kind of a tool in the bag there. The Gaines lens test, another one that we'll do clinically, looking for SI joint pain provocation, and lying supine at the side of the table. You'll have them scoot to the very edge of the table. I more commonly will do it as this woman's doing it here, have them move to the edge of the table, flex the ipsilateral hip and knee to the abdomen, have the patient clasp their hands behind the thigh, and then I'll put a flexion force on that contralateral knee, put a downward extension force on the examining knee, and looking to see if that produces pain over the SI joint area in the back where they usually feel. Somewhat decent sensitivity, not great specificity, but again, another test you'll see done for SI joint pain. You'll see a running theme here with SI joint provocation tests is there's really not any great tests that are reliably done for SI joint pain. Really, the effectiveness comes when combining multiple tests. So you'll see most studies that have looked at SI joint provocation tests, you're looking to do, if it's really in your clinical differential, I usually do at least 3, if not 5. They're quick to do, they're easy to do, and the patient's typically in the same position. And so the more tests that you can get positive when looking for this, the more likely that there's an SI joint issue. Up there, this gentleman's demonstrating the compression test for SI joint provocation. Specificity is close to 90 to 100%. Personally, I think that's a little bit high, but at least that's what one of the good studies that I found showed. Pretty poor sensitivity. And then the midline sacral thrust test, as this guy's demonstrating here, you just have the patient lying prone, put a downward force over the superior aspect of the sacrum, looking for provocation of their pain. Standing flexion test, it only indicates asymmetry in motion or loss of lumbopelvic rhythm. So basically, you're looking at a loss of motion, and then typically that altered motion is not always synonymous with pain. And essentially, you've got the patient in standing, their feet are about a foot apart. I place my thumbs on their inferior aspect of each PSIS, and I ask them to bend forward with both knees extended. One study showed some specificity of 79%, and again, you're looking at some loss of motion, and then you're asking about pain. Is it associated with pain? But again, that altered motion is not always synonymous with pain. So you're looking at an unevenness in motion when they bend forward. Again, just wanted to put this up to demonstrate what I had alluded to before. When these tests are most effective when combined with each other. In this study, they looked at specifically four tests, 2 of which I haven't commented on previously. I don't do them very much clinically, but whether it's the test that I mentioned before or the 4 mentioned here, what's important to note is the more if you're doing some, pick 3, pick 4, pick 5. When you're really concerned that there might be an SI joint problem, learn how to do them appropriately and relatively quickly but efficiently. And if you're getting a majority of those tests being positive, it raises an antenna that there may be some SI joint dysfunction going on. And then I believe lastly, I wanted to comment on something that's I know been alluded to as far as tests for non-organic pain generators. So looking at Waddell's signs. Waddell did a bunch of studies back in the 80s and 90s, and some of them happen to include looking at tests that can associate when you feel like a patient, you're not seeing a mechanical source of the pain in your history and your test taking or your examination, and you're trying to piece together, is there something else going on here that's not related to a somatic source of their pain. And so, however, there's little to no association in checking these signs for secondary gain or malingering. However, they noted that when there's three or more of the five positive, then that was significant for a potential non-organic pain generator. Those are, without going through the specifics, they are distraction, so attempting to distract a patient while performing a maneuver and seeing if they suddenly don't notice that they have pain. Looking at regional disturbances, non-anatomic pain disturbances, looking at a simulation test, i.e. Some sort of sham test where maybe you put an axial load in somebody who has back pain and put an axial load down, or do a sham rotation and seeing if that stimulates back pain where it typically shouldn't. Tenderness to skin pinch, so that's a non-anatomic pain. If you barely kind of push on their skin or pinch their skin, does that cause pain? And then an overreaction. Again, that's somewhat controversial, but you can get an overreaction to some of the different testing that you're doing with them. And I want to get to, I know I'm running a little short on time. I do want to get to the demonstration video because I think that's going to be most helpful. But just I did put a slide in here on diagnostic imaging, appropriate initial and potentially advanced imaging when evaluating for low back problems. Additional testing to consider, electrodiagnostics or an EMG and the appropriate pediatric population, or when the clinical symptoms or history warrants it. Labs to consider, the most common ones that I'll do to screen for underlying metabolic or hormonal abnormalities, or potential source of infection that's a cause of their back pain in the right patients. I put those there. And now, I want to go through this. So this was a lumbar exam demonstration that I did. Main thing to note here, it's about a 10-minute video. I'm going to try to narrate through it. I think we're going to run a little short on time. I may try to hit the most notable aspects of it. You can do this in much less than 10 minutes. In fact, I was trying to narrate through it. I'm going to do that myself today as we go through it, but obviously that slowed us down a little bit. So this is something that I commonly will do in clinic that doesn't take more than 4 or 5 minutes once you get used to doing it. So you'll notice I've got him starting standing here in order to assess gait, in order to assess range of motion and some various things. I like to try to minimize positional changes. That way I'm not having them get up and sit back down and then lie down and then get back up. So I'll always start with them standing, do everything I need to do there, move to them sitting, do everything I need to do there, and then from the sitting position, go ahead and lie them down. So here, I start with just assessing. Typically, I'll have them kind of walk down the hall just to assess their gait. Then here, within the room, I'll have them walk across the room doing toe walking. Really, they're looking for, in all of these, like I mentioned before, looking at balance, looking for any balance issues. Excuse me. And then in that heel walking, looking at dorsiflexion strength. It's a good functional test for dorsiflexion strength, as well as in toe walking, looking for plantar flexion strength. And then here, once done with that, move on just to assessing them from the posterior. We'll look for any shoulder asymmetries. Also, palpate out their iliac crests. Look for any pelvic obliquity, potential leg length discrepancies there. Also get a good look at the spine. Does it look pretty straight? Does it look abnormally curved? I'll also there very easily look for any scapular asymmetries. Does it look like they have a wing scapula? Or if I want to look for any scapular dyskinesis, I can put them through a shoulder range of motion. Do a quick Adams forward bend test. Can look for any rib prominence. This guy does not have any. He's got a pretty good straight spine. Look for any lumbar fullness. Really looking for any asymmetry. And then also, while he's there, I can assess his range of motion. Important, I want him to keep his knees straight and hyperextended. I don't want him to flex them. If he starts to flex them, he's gone too far. I want him to go down until he can't with his knees extended. I will describe that clinically as where his fingertips are able to touch. Is he able to put his palms on the floor? Can he touch his fingertips to the floor? Does he do his fingertips go to his ankle joint line or more proximally? Can he not get past the knees? That's a severe loss of lumbar range of motion. I'll take them through extension as well, and then with flexion and extension, I'll also ask, hey, does one of those or the other cause more pain? Just again, hinting more clinically at does flexion or extension cause more pain? I've already gone through through rotation, and then side bending, and then there I was checking for the stork test, looking for any provocation of pain with hyperextension of the back and hip. And so there he's doing the side bending. So now we've gone to sitting. Excuse me. Checking strength. This is where I'll do the majority of my muscle myotomal strength testing. So checking for knee extensor strength. I'll ask him to point his toes and foot and toes to his nose. And usually most kids will understand that. If they don't, then I do it myself and I point my toes to my nose. Checking for dorsiflexion strength. At the same time, I can check for great toe extensor strength. And then likewise, can check for plantar flexion strength, again, in this in the sitting position. No, you don't have to do that again. You already did it with them standing and walking across, but again, if they were having trouble with that, then you can do it with them sitting. I'll then do sensory testing. I'll start with the arms, presumably if they're there for a low back issue and don't have, symmetrical stocking and glove sensory complaints. I'll start with the arms and hands. Hey, this feels soft, right? Same on both sides, pretty soft. So I'll start in the upper thigh and leg and go down. I'll try to go in a little bit more of a dermatomal distribution. Go all the way down the lateral aspect of the upper and lower leg, the anterior aspect, the medial, posterior. I'll go down to the dorsal foot, the deep perineal nerve area, which is in that first and second toe web space, and then, the plantar surface of the foot. Here, looking for neurological long track signs, so checking deep tendon reflexes, the patella, the Achilles. In the Achilles, I find it most helpful to put them in slight dorsiflexion, just to put some tension on that Achilles tendon, and looking for an ankle jerk. And then from there, can do both ankle clonus testing as well as plantar stimulation. I'll take the bottom of the reflex hammer and just swipe. Let them know, hey, I'm going to do a light swipe across the bottom of your foot. Both of those responses are down going. If that big toe fans up, I'll usually check it again just to make sure it wasn't. They're not withdrawing. So often they'll be very ticklish with these, so you got to take them with a little bit of a grain of salt. If they withdraw, I usually just note that as a withdrawal response. And here, checking for ankle clonus, a quick dorsiflexion jerk. You're looking for that a beating clonus of the ankle, and then you describe that as 1 beat, 1 to 2 beats. I had one yesterday that was 5 beats of clonus, or is it sustained, meaning you do it and it's sustained clonus jerk of that foot, indicating more of a central nervous system, an upper motor neuron sign. Here I'm just illustrating the sitting slump test. So you're putting neural tension on that sciatic nerve. You lift the leg, dorsiflex the foot. You can even have him put his chin to his chest, all trying to increase the neural tension. Here with him now supine, I like to check hip strength, hip flexion strength supine rather than sitting, because they can compensate for that a little bit more. So I'll check hip flexion strength. There, I'm just demonstrating how I check an abdominal reflex. And then I'll take them straight into a straight leg raise. Really focusing on, are they getting that radicular shooting pain down the leg, down into the lower leg, into the foot, or provocation of numbness or tingling where they didn't have it before, between that 30 and 70 degree angle of hip flexion. And then often I'll even put a little bit of dorsiflexion on their foot, or if I'm really concerned that they may have a radiculopathy, even ask him again to raise his chin and put his chin to his chest. I'm sure I had something riveting there to say. She can't hear it. I think I'm commenting on the contralateral straight leg raise. So for instance, if I was concerned of a left-sided radiculopathy, not on the right, I'd lift the right, and does that provoke radicular symptoms in the left leg? Would be a positive contralateral straight leg raise. Here, also, again, if I'm concerned for underlying hip pathology, I just take him right into hip range of motion. You can see his hip flexor there on the left is just a little bit tight. Ideally, that hip should stay flat. When you flex the contralateral hip. So there I'm taking him into internal range of motion, external range of motion, and then I'll usually assess that at degrees. You can see where I was there is at neutral, so then I describe that as how many degrees from neutral, and then slide right into a Faber test, putting some distraction force on the contralateral iliac crest while putting a distraction force on that knee. Again, does that provoke your pain? If so, is it in the groin? Potentially more related to hip joint pain versus in the posterior aspect, which is a little bit more SI joint pain. This is the Gainsland's test, like I was describing earlier. Have him hang that leg, hyperextend or extend that hip off the table, flex the knee, and then I'll put, again, another distraction force, trying to stress that SI joint of the hip that I'm extending there. Does that provoke pain? And then I'll typically ask them to pull to their chest. Here's the SI distraction test, where I just quite literally put both palms on the aspects of both ASIS and put a distracting force to see if that provokes SI joint pain. Here's that SI compression test that I was describing earlier, where you're, again, finding the iliac crest and put a downward pressure. Does that provoke SI joint pain? Can also palpate the greater trochanter while I'm there, see if they have any over that prominence, and see if they have any trochanteric pain, hinting at maybe bursitis or gluteal tendonitis. Here I can check their hip abductor strength if I need to. Also doing an Ober test, which I didn't comment on earlier, but that's really a test to look for a motion restriction in the IT band. So when he's lowering his knee there, could he lower his knee behind the other leg? Does it touch the table? If it touches the table, it generally tells you they have pretty good motion. If it does not, or there's space between the knee and the table, hence there may be a motion restriction in their IT band. It may be tight. And then here I'm checking the femoral nerve stretch test. So I can forcibly flex the knee with him in prone. Does that reproduce femoral nerve symptoms, radicular symptoms? And then one step further, do I want to take it a step further and extend his hip, further putting a stretch on there? And that was it. So in conclusion, and some takeaway points today, really, although this talk was on the thoracic and lumbar exam, it's really history, and you got to know your anatomy if you're going to do a strong palpation exam and lumbar exam. Always remember to check for red flag symptoms. Imaging, provocative maneuvers, and pain patterns are generally of limited value in the lumbosacral spine, but can help augment your differential. And the above in context of the history and symptoms should guide your workup and treatment. References today, and that's all I've got. We'll open it up to questions and any other comments you may have.
We have any questions from the audience? Dr. Petrasic, I thought that was a great evaluation of the back, and certainly learned a lot, and appreciate you telling us about all of the tests, particularly the special tests. And one of the things that we had several questions, to be honest. I'm going to try to combine them into a couple statements, but
Sure.
Barring our screening for the red flags, a lot of adolescents will just have back pain without a red flag. And that's probably, I don't know, I'd guess 90 to 95% of the ones that we see. At what point do you recommend an x-ray or an MRI or perhaps a referral to a specialist when an adolescent presents with back pain with no other red flags?
So it's a great question. And it's a little bit different for me versus what I would, as somebody that's evaluating the back pain, the specialist evaluating it. But you might get a different answer depending on who you ask. What I usually go with is, as far as, so there was a couple of questions in there as far as x-ray, referring to a specialist, an MRI. I will typically get an x-ray if, in an adolescent, if there was trauma, so was there an injury or a traumatic accident, were they in a car wreck and they started having back pain? If you also factor in the age there, again, I'm seeing adolescents, so I'm not seeing 5-year-olds, so that the younger you get, obviously, the more you're worried about radiation exposure. But if they've been having pain for longer than 3 weeks to a month, some might do 3 months. In somebody with atraumatic back pain, again, typically if they're coming to me, I'm gonna go ahead and get an x-ray. If you're in primary care, you might take, if they've got no red flags, they've got no neurologic symptoms, and they've got it's more myofascial pain when you push, you might consider just setting them up, and again, you're thinking there isn't anything more serious, you might even forego the x-rays then. But if you're in primary care, I would, again, typically wait till maybe about 3 months once you've tried a standard course of therapy. Again, if there's ever any question or you've got your antennas raised or you think there may be something there, then go ahead and get the x-ray. But typically when I see them, if the patient, if it's more acute pain, I'll typically I'll tell my staff I'm going to examine them first and then we'll decide. But if it's been there for 3 to 4 weeks or longer, I'm likely going to get the x-ray because I'd be remiss if I didn't at that point, because they're already there to see me, and if they've made it to me, then typically it's a little bit longer standing pain. In regards to the MRI, typically I won't do that unless there's either neurologic symptoms, there's red flags in their history that I'm concerned about, or they've already failed we've already done conservative treatment. Maybe we've ideally already done x-rays, because I'm going to do x-rays always before I do an MRI. And again, they've almost kind of earned one at that point. If they're having constant pain, it's not getting better with conservative treatment, then we want to roll out some of those zebras as well. So, but typically that's much more the exception than the rule. Usually I'm looking for the neurologic symptoms or the red flags. And then MRI, X-ray, what was the other? Oh, referral to a specialist.
Answered it with the
and that kind of goes on to answer. That's typically when I would refer to a specialist if I'm considering ordering an MRI.
So you just brought up another question that came through, but could you just give us a 1 or 2 liners on how you define myofascial pain?
Yes. So the way I describe it to the kids when I tell them, hey, I think you have myofascial pain, because I'll more direct that to the parent, and then both to the parent and the kid, I say, look, myo is muscle, like I mentioned in the talk. Fascial is the thick connective tissue that envelops the muscle, so soft tissues, right? So when you're having myofascial pain, you're having that muscle or soft tissue related pain, whether it's the muscle, the tendon, the fascia, there's a soft tissue source. It's also reassuring. I tell them, look, this also means that you don't have, I'm not seeing anything that's wrong with your spine. Your spine looks healthy. The spine looks good. I'm not concerned there, but there is this myofascial source of pain, whether it be from strain, whether it be from inflammation, whether it be from simple tightness, and that causing further muscle fatigue on the surrounding structures that we need to address. So hopefully that answers the question.
And on exam, would you say it's typically more tender?
Oh, yes. Yeah, absolutely. So they're going to have myofascial tenderness. Great point. Typically, if they've got not always, but typically they'll have myofascial pain in like those paraspinal muscles or the muscles of the low back that I'm palpating. I think the other time that you could consider, and you may just call it, let's say, bilateral hamstring tightness. I think that's a type of myofascial pain that may not be tender, but when you check their hamstrings, they're extremely tight. Maybe their hip flexors are tight, their hip rotators are tight when you're checking range of motion. But that kind of tension on the pelvis and the spine over a period of time can cause muscle fatigue and that feeling of tightness, soreness, and pain when they're in positions for a long time. So that can also kind of be a myofascial pain.
Great. Just a follow-up question to that, but just a follow-up question to that, but again, would reiterate, fantastic talk, a lot of good reference. I think this is a, kind of refer back to it kind of talk, especially that video was great. And I'm really looking forward to the subsequent talk of treatment modalities for thoracolumbar pain in the adolescent. Along those lines of myofascial versus other, one of our, big populations is lumbar pain, most often musculoskeletal in origin, really muscular in origin, but any tricks to differentiate facet and posterior element pain versus sort of lower lumbar muscle pain? For example, our football players, our gymnasts, that population where it's all right in that area. Many of the exam findings are the same. Any tricks on that?
Yeah, there's not, I'll preface it with there's not a great test, because I think anybody with lumbar pain, whether it's posterior element pain or even just lumbar myofascial pain, is going to have, there's a good chance they're going to have a positive stork test. Honestly, I've found that, one, the history of the repetitive loading, typically if they're getting more pain with hyperextension, if that's going to cause pain more in the posterior elements than the lumbar muscles, the myofascial tissues. Typically, like with any muscle, it's going to hurt more when you stretch it. And so more with forward bending, you're going to get a little bit more of that soft tissue pain when you bend and stretch those muscles, or when you tighten those muscles versus just simply extending. And so it's kind of that differentiation of what's aggravating the pain, and two, what can I do to provoke the pain, or what does the patient tell me they do that provokes the pain, to help differentiate between the two.
Fantastic. Thanks again for the review.
Sure, of course.
I just want to thank you once again for giving us that great talk. And what we'll do is I would encourage anyone to, on his last slide, he's got his email address, Dr. Petrasic, and he also has some great, excellent pearls, particularly a lot of the comments about the imaging and his clinical exam that you can always go back on that PowerPoint and reference to as well. I want to thank everyone for joining us live, or if you're on demand in the future, don't forget to sign in for your CMEs. We've got a great lineup to end up the rest of the year. Next month, we are going to highlight the research that we've produced at the Sports Medicine Center and at Scottish Rite in Frisco. So we're going to give some research presentations and highlight some of the research that we've done over the last year, and we've presented on the national stage. We're going to bring it to you here in person, and then subsequently in November and December, we are also going to explore the back one more time with Dr. Brooks, as well as an examination of a pediatric foot and ankle exam as well. So look out for those emails, those e-blasts, and those flyers, and thank you again for joining us.